you.
Hello, and welcome to today's virtual side event as part of the United Nations Conference of States Parties to the Convention on the Rights of Persons with Disabilities, free from discrimination, violence, and coercion, upholding the right to bodily autonomy and informed consent for women and girls with disabilities. My name is Christian, and I will be your Zoom technician for today's session. Before we start the session, I'd like to run you through the accessibility features that are available to enhance your access during the session. You should note, as this is a webinar, your video and microphone will be turned off throughout the duration of this session. Please take a moment to familiarize yourself with the control panel below, which is usually found towards the bottom of your screen. Closed captioning has been enabled for this session and is currently being offered in English. To utilize it, please click on the Show Caption button within your control panel. To utilize the French caption, please use the external link provided in the chat. Transcripts will also be shared with participants after the conclusion of the session. Additionally, both language and sign language interpretation have been enabled for this session and are currently being offered in French and Spanish language, and in International Sign and British Sign Language interpretation as well. To use these features, click on the interpretation within your control panel and select the interpretation of your choice. Please note that you should select the American Sign Language option if your intention is to use the International Sign Language option. The session is being recorded. You'll receive a notification when recording starts and a prompt to consent. If you do not consent to recording, you may leave the session. Should you have any questions related to the content of this session, please use the Q&A feature within your control panel, and our panelists will do our best to answer as many questions as possible. Finally, should you encounter any technical difficulties throughout today's session, please let us know using the chat feature. With that being said, I will now pass over to the moderator of today's session, Anne Delorme, Executive Director, Human and Inclusion Canada. Thank you.
Hi, everyone, and welcome. We have an action-packed panel today. My name is Anne Delorme. I am the Executive Director of Humanity and Inclusion Canada. I'm a white woman with short blonde hair, and I'm wearing a black blazer today. Humanity and Inclusion is an international NGO that builds on 40 years of experience working alongside persons with disabilities and vulnerable populations to improve their living conditions and to promote respect for their dignity and fundamental rights. In more than 50 countries worldwide, HI is one of the few global leaders working on disability inclusion in the health sector and is a leading actor on sexual reproductive health and rights globally. According to the recent World Health Organization's report on health equity for persons with disabilities, the female disability prevalence rate worldwide is 18%, 80% of which live in low-income countries. Despite legal frameworks stating that women with disabilities have the same sexual and reproductive rights as women, they face multiple barriers to accessing fundamental SRHR education, information and services, including access to comprehensive sexuality education and modern contraception. These barriers relate to stigma, stereotypes, and misconceptions. Women with disabilities are frequently seen as non-sexual beings, incapable of engaging in romantic relationships, and unfit for motherhood and parenting. The consequences of such misconceptions is that women with disabilities are discriminated against, and they're seen as unable to decide for themselves. Their decision-making power and bodily autonomy are constrained by their families, caregivers, and health workers. Women with disabilities are at greater risk of being forced into pregnancy or subject to coarse procedures, such as forced sterilization, abortion, or contraception. They are also more vulnerable to violence, including sexual violence. Between 40 and 68% of young women with disabilities will experience sexual violence before the age of 18. Drawing on the lived experience of women with disabilities and healthcare providers, this panel today will seek to identify existing gaps and showcase examples of good practices around the world in informed consent for women with disabilities utilizing sexual and reproductive health services. Some solutions and recommendations will be proposed, but there's still a long way to go, and so much more remains to be done. The panel is split into two sections. In the first part of today's webinar, Seri Wendoh from International Planned Parenthood Federation will explain what reproductive coercion is and what forms it takes. Then Rosario Galarza from the International Disability Alliance and Janet Ajangi from the Lira District Disabled Women's Association, Uganda, will discuss why women with disabilities are at heightened risk of sexual reproductive rights violations. Afterwards, two SRHR service providers from IPPF's member association, Reproductive Health Association South Sudan, will share experiences and challenges when it comes to SRHR care provision and informed consent of women with disabilities. In the second part, as I mentioned, it's an action-packed webinar. In the second part, different speakers will shed light on possible solutions and recommendations. Rosario will talk about the importance of a rights-based and intersectional approach, while Dr. Mamoudou and Dr. Gisela will share examples of good practices of inclusive SRHR, or sexual reproductive health and rights programming, from the HI project portfolio in West and East Africa. Ingrid van der Heijden, feminist, gender inclusion researcher, will present recommendations from Inclusive Informed Consent Guidance, which she produced as a consultant for humanity and inclusion. And the session will finish with a call to action from Rosario Galarza. So let us begin with the first part. So I'm going to welcome Seri Wendoh. Seri Wendoh holds a doctoral research degree on the intersections of gender, race, and class, and is a global leader for gender and inclusion at the International Planned Parenthood Federation, where she provides guidance and technical support on gender, inclusion, and SGBV programming. Seri, what is reproductive coercion and what forms does it take? And how is it considered a form of gender-based violence or a violation of women and girls' sexual reproductive rights?
Thank you, Anne. What you have said cannot be emphasized enough. So allow me, if I can just take us back a little and provide some background to why reproductive coercion is a violation of rights. So sexual and reproductive health and rights are human rights. They're not only integral part of the right to health, but are necessary for the enjoyment of many other human rights, including the right to life, freedom from torture and ill treatment, freedom from discrimination, equal recognition before the law, privacy, and respect for family life, education, and work. Sexual and reproductive health and rights encompass the right to have control over decisions concerning sexuality and reproduction without discrimination, coercion and violence, and the right to access a range of sexual and reproductive health facilities, services, goods, and information. These rights are clearly set out in the Convention on the Rights of Persons with Disabilities, including Article 12 on equal recognition before the law, Article 23 on respect for home and family, Article 25 on the right to the highest attainable standards of health, and Article 16, freedom from exploitation, violence, and abuse. Yet, due to multiple and intersecting forms of discrimination on the basis of gender and disability, women and girls with disabilities face unique and pervasive barriers to full realization of their sexual and reproductive health and rights. For these and more reasons, disability inclusion and gender equality cannot be achieved without addressing the sexual and reproductive health and rights of women living with disabilities. It is well known that intersecting inequalities and discrimination, including on the basis of race, ethnicity, caste, status, location, sexual orientation, and gender identity, all these entrench multiple gendered barriers in the way of accessing services and related support. For example, as Anne has said, women with disabilities face a higher risk of experiencing early marriage, sexual violence, and unwanted pregnancy. Equally, the intersection between young age, disability, and gender results in both aggravated forms of discrimination and specific human rights violations. Again, as we have already had, the forced sterilization of girls and women with disabilities represents widespread human rights violation across the globe. Stigma and stereotypes based on gender and disability often lead to structural or systemic discrimination, in particular when exercising sexual and reproductive health and rights. This is why reproductive coercion represents a significant threat and violation of rights. Reproductive coercion refers to behaviors by a partner to interfere with an individual's reproductive health decisions and behaviors. The most common forms of reproductive coercion include sabotage of contraceptive methods, pregnancy coercion, and pregnancy pressure. This behavior includes explicit attempts to impregnate a partner against her will, control outcomes of a pregnancy, coerce a partner to have unprotected sex, and interfere with contraceptive methods. And for women and girls with disabilities, this might not even always be a partner. Sometimes parents or caregivers can, in an attempt to protect their children with disability, for example, force an adolescent girl with disability to start taking contraception. These violations more often than not occur, as we have had, in the home, in the school, in community and health settings. And we also know that though no health provider sets out to violate the rights of women and girls with disabilities, if we don't create an enabling environment within our health settings, we are putting healthcare providers in situations that can result in discrimination and coercion. Therefore, an enabling environment within our health settings is critical for addressing reproductive coercion. In health settings, increasingly, evidence-informed models that combine research, i.e. understanding the context, trends, and reality, training health providers in the provision of first-line support at a minimum to women and girls experiencing reproductive coercion is gaining traction in sexual and reproductive health settings. The gaps that we see is that this is not always matched with inclusion of women and girls with disabilities. And equally, partnership with and between national sexual and reproductive health and organizations of persons with disabilities is leading to increased engagement, reduction of mistrust, and enabling care and support to those who most need it. These models of care can lead to a reduction of coercion and intimate partner violence, and in fact improve the reproductive health and autonomy of women and girls living with disabilities. Health providers are uniquely placed to address reproductive and sexual coercion that can lead to improved health outcomes by supporting inclusive, accessible information, communication of health information, counseling, and signposting clear referral pathways to community and related social networks. These, as well as supported decision-making. Further interventions would include harm reduction strategies and prevention of unintended pregnancies by offering long-acting methods of contraception that are less detectable to partners. But this is not all. Concerted multiple efforts are needed to strengthen infrastructure, build evidence, especially where women and girls with disabilities are concerned, and bolster health provider competencies to meet the needs of these women and girls. We also need sexuality education that is comprehensive and inclusive and meaningful. We need models of care that offer integrated sexual and reproductive health services. We need quality of care that embeds indicators on disability and enabling policy frameworks that allow the enjoyment of sexual and reproductive health and rights, free of coercion, stigma, and discrimination. It is time to build this momentum. And central to all these interventions is individual choice and bodily autonomy. Thank you.
Thank you so much, Seri. And, despite the fact that we have made these gains around various conventions that protect our rights, there's still so much work to do to ensure that women with disabilities can fully exercise these rights. I'd like to welcome now Rosario Galarza. She's the Intersectionality Officer at the International Disability Alliance. She's responsible for strengthening the inclusion of women with disabilities and underrepresented identities in IDA's work. She's one of the lead trainers of the IDA Bridge training at the global level. And prior to joining IDA, Rosario worked as a human rights officer for RIADIS, so RIADIS, where she supported OPDs, so organizations of people with disabilities, in the implementation and monitoring of the CRPD, the CEDAW, and Agenda 2030. And she prioritized activities related to the rights of women with disabilities and other underrepresented groups. Welcome, Rosario.
Thank you so much.
Why are women and girls with disabilities at heightened risk of reproductive coercion?
Okay, thank you so much for the invitation. And yes, women and girls with disabilities are at heightened risk of reproductive coercion due to a combination of societal attitudes, discriminatory practices, and barriers they often face. Here are some reasons why they may be more vulnerable to reproductive coercion. First, power imbalances. Women and girls with disabilities may experience a power imbalance in relationships where their partners and family members, where they exert control over their reproductive choices. This can be a result of societal perceptions that people with disabilities are dependent or not capable to make decisions for themselves. Then we have the lack of autonomy. Women and girls with disabilities may face limitations on their autonomy and decision-making abilities. This can be due to societal attitudes that undermine their agency or restrictive legal frameworks that allow others to make decisions on their behalf without considering their preferences. Then we have communication barriers. Some women and girls with disabilities may face challenges in communications which can impede their ability to express themselves, their opinions, desires, and make informed choices about their reproductive health. This can make them more vulnerable to coercion or manipulation. Then we have limited access to information and resources. Women and girls with disabilities often encounter barriers in accessing comprehensive sexual and reproductive health information, services, and support. This lack of access can leave them more susceptible to coercion, as they may have limited knowledge about the rights and available options. Now we have stereotypes and ableism. Prevalent stereotypes and ableism contribute to the marginalization and devaluation of women and girls with disabilities. These biases can result in their needs and experiences being overlooked or disregarded, increasing their vulnerability to reproductive coercion. And now we are going to explore some documented cases of rights violations against women and girls with disabilities, including instances of forced sterilization, coerced contraception, forced abortion, and denial of reproductive health care. Testimonies from survivors have highlighted the violation of their bodily autonomy, loss of reproductive choices, and the psychological and emotional harm inflicted upon them. For example, there have been cases where women and girls with disabilities have had their children removed from their care based on the assumption that they are not capable of being good parents due to their disability. Such actions not only violate the reproductive rights, but also perpetuate harmful stereotypes and discrimination against people with disabilities. Addressing these issues requires a multifaceted approach that includes promoting autonomy and self-determination for women and girls with disabilities, combating ableism and stereotypes, providing accessible information and services, and implementing policies that protect the reproductive rights. The Convention on the Rights of Persons with Disabilities offers a really comprehensive framework, recognizing the rights of persons with disabilities, including women and girls, to enjoy the highest attainable standard of health without discrimination.
Thank you, Rosario. You know, I can already see how we kind of want to dig into each speaker, but unfortunately we'll keep going and move on to hear from Janet Ajangi, who is a woman with a disability. She's also the mother of 3 children and a member of the Lira District Disabled Women's Association in Uganda, which is a partner organization of Humanity and Inclusion's Making It Work project. This project fights, well, rather supports women's rights and disabled women's organizations in their work on advocacy and fighting against gender-based violence. Welcome, Janet. Could you share with us some examples of violations of sexual and reproductive rights at healthcare level that women and girls with disabilities face in your context and from your experience?
Thanks, Anne.
Yes.
First, some girls and women with disabilities are subjected to forced contraception. The relatives of girls and women with intellectual disabilities, in particular, take them to the health center to get injected with contraceptive without informing them what is going to happen and without getting their consent. And this happened mostly in the private facilities. Also in the same private facilities as well, girls with disabilities, disabilities around 16 and above are sterilized without getting their consent or even being explained about it. Due to the cost of the procedure, this is happening mostly in the urban areas and in families who can pay for the surgery. Last, in some facilities, some health professionals, some nurses still have negative attitudes towards women, pregnant women with disabilities, blaming them and so on. It is making the mother really fear to get to the health facility. This brings negative impact for the health of the mother and the baby to come, as they will not attend antenatal care. Thank you.
Thank you, Janet. And could you share a couple of actions undertaken by LIDWA, your organization, that have been decreasing or successful in decreasing the SRHR violations of women and girls with disabilities?
LIDWA is continuously raising awareness about SRH for women and girls with disabilities to the government and the women themselves to remove misconception, stigma, and discrimination. This is targeting the community at large, the local government, and the women themselves. As well, we are engaging with local leadership. The district health office has come out with some measures to allow better access to women with disabilities to health services, including reproductive health. And this is also for survivors of gender-based violence. LIDWA has been establishing GBV committees at the community level, and we also have focal points in each parish of the sub-counties where we work. These focal points are women with disabilities themselves. The committees support effective referral pathways for GBV survivors and can report problems. Last, LIDWA has been training the health sectors in the issues of gender-based violence, GBV management, others. We have been discussing with them around the different types of disabilities and also the issues around the consent and the rights of women with disabilities. Thank you.
Thank you very much, Janet. And it's so important as we understand both the more academic or the data related evidence that allows us to understand the heightened risk to sexual reproductive health and rights violations that face women with disabilities. And then you, Janet, giving us some really clear examples from Uganda and from the work of your organization. I'd like to continue in that perspective and introduce two SRHR service providers from South Sudan. So Savia Juan Jackson is a community-based contraception counselor, and Jane Modong is a midwife and SRHR service provider. And both are working for the Reproductive Health Association of South Sudan, which is a member association of IPPF. So Jane and Savia, I'd like to bring it over to you to share your experience in obtaining informed consent and providing contraception to women with disabilities.
One of them was the communication barriers. We found it very difficult to communicate with the person with the hearing impairment, the negative attitude towards women with the disability at the service level. So we also have a lack of accessibility. Most of our static clinics, they were not accessible by a person with the disability. It is very important to involve them, the person living with the disability or the OPD, the organizations, so that they help us during the mobilization process. They need to be involved during the mobilization process so that they could be able to coordinate to those ones who have the hearing impairment. They will be able to understand themselves. We said for family planning counseling, it depends from the orientation of the clients, from the level of understanding of the person. So sometimes we take 15 minutes, others may take even 10 minutes when they are well oriented.
Thank you so much for giving me this opportunity. I'm a young girl with a physical disability. This hairstyle of mine is bob style. We call it bob style in South Sudan. The color of my dress is elegant. I'm sorry I didn't wear a necklace, but I have a white earphone that I'm using. To start with answering the question, yes, challenges that the service providers face when delivering service in South Sudan. To make it briefly, the major challenges that face in South Sudan. One is the negative attitudes towards women and girls with disability. You know, most of the service providers, they were not much knowledgeable about the rights of girls and women with disabilities. So that's why you find that they always give negative attitudes to women and girls with disabilities. I always work as a community-based distributor, and most of my work is a field work where I move from door to door or I move around the community. It was a home that I went to, so when I reached to that home, I asked, because normally when I go from home to home, before I started counseling, the first question I asked, is there women's or women or girls with disability in this family, because we realize that women and girls with disability, they are really isolated with their family due to the negativity that they have towards girls and women with disability. So when I went there, I asked, is there a girl or woman with disability in this family? I got two response answers. One says no, and the other one said yes. And when I asked again, I said, okay, the reason why I asked this, because we are all the same and we are all human beings without discrimination. And therefore, we can't do services excluding others outside. And when they saw that I was quite serious, they have to say yes. And the girl was called. So sometimes we look at the issue that we will say that communication is a barrier to girls or women with hearing impairment, but then we don't look in other way of communication. There was a home that I visit. I found a young girl with hearing impairment. Imagine me, I was not trained on how to communicate, on how to use a sign language interpreter, yeah? But then I find myself in a situation that I have to use my sense. Okay, why can't I use the pen? Maybe she's educated, so it's not good to judge the book from the cover. I wrote for her the name of the medicine. I demonstrate to her, like today you take one. Tomorrow you take one. Next, you see, she was really happy actually. She was very happy. There's a lot of negative attitudes towards women and girls with disability, honestly. So those concepts, we need to remove those concepts. How can we remove those concepts? We need to train them, and we need to tell them, we need to give them knowledge on how women and girls with disability are important, are having right to access when it comes to health.
Wonderful. So thankful of Savia and Jane for preparing that video and sharing some of their experience. And, you know, the first part of the panel was a bit more focused on the problems, but we can see that already we're getting to some of the solutions and recommendations so that we can fight and address sexual reproductive rights violations for women with disabilities. So we're entering now into the second part of the panel, and we're going to continue with this idea of focusing on solutions and recommendations to make access to SRHR services inclusive, and to take a look at different recommendations to ensure informed consent for women with disabilities. So I will quickly hand it over to Rosario again. Tell us, Rosario, why is it important to ensure that persons with disabilities know their rights to health, particularly around sexual and reproductive health and informed consent?
Thank you. Informed consent is a fundamental principle in healthcare, ensuring that individuals have the rights to make decisions about their own bodies and medical treatments. A person with disabilities should be informed about their rights to give or withhold consent, particularly in matters related to sexual and reproductive health, where autonomy and personal choices are crucial. It is really crucial to ensure that persons with disabilities are aware of their rights to health, sexual and reproductive health, and informed consent for several reasons. The first reason especially is about equality and non-discrimination, because persons with disabilities have the same rights as everyone else, including the right to health. Ensuring that they are aware of their rights helps promote equality and non-discrimination, allowing them to access healthcare services on an equal basis with others. Then another reason is decision-making and autonomy. Women and girls with disabilities who are aware of their rights understand that social model of disability emphasize that disability is not solely an individual impairment, but is largely shaped by societal barriers. Women and girls with disability who know that they are right holders are encouraged to make their own decisions over their own bodies and reproductive choices by developing autonomy and agency. The other reason is empowerment and self-advocacy. Knowledge of rights empowers individuals with disabilities to advocate for themselves, and make informed decisions about their health. When they are aware of their rights, they can actively participate in discussions and decisions reflecting their health, including sexual and reproductive health. Access to equality healthcare is another reason. By knowing their rights, individuals with disabilities can demand and access quality healthcare services that meet their specific needs. It helps healthcare providers recognize the importance of accommodating disabilities and providing inclusive healthcare services, resulting in better health outcomes. The other reason is prevention of abuse and exploitations. Persons with disabilities are often at higher risk of experiencing abuse, neglect, or exploitation. Understanding their rights, including those related to sexual and reproductive health, can help protect them from coercive practices, forced sterilization, or any form of violation. And also the other reason is policy and legal advocacy. Knowledge of their rights enables individuals with disability to advocate for policy changes and legal reforms that promote their access to healthcare and protect their rights. When they are aware of their rights, they can actively engage with organizations, policymakers, and disability rights advocates to create positive change and in healthcare systems. Overall, ensuring that persons with disabilities are aware of their rights to health, sexual and reproductive health, and informed consent is essential to promoting their autonomy, inclusion, and overall well-being. It helps foster a society that respects and upholds the rights of all individuals, regardless of their disabilities. Thanks.
Thank you, Rosario. And I think we cannot emphasize enough a rights-based approach, which is at the heart of moving away from a charitable model to empowering and focusing on decision-making and bodily autonomy. So thank you for raising that. Our next panelist, Dr. Mamoudou Barro, will explain how access to comprehensive sexuality education for adolescents with and without disabilities can enable adolescents to be agents of their SRHR rights, their sexual and reproductive rights, and contribute to reduce gender-based violence. Dr. Mamoudou is a medical doctor, specialist in public health and sexual reproductive health, and he is the project manager for the Projet Ensemble, which is a Global Affairs Canada, a Canadian government-funded project with humanity and inclusion in 3 West African countries. The project aims to improve access to sexual reproductive health services and rights with a focus on women and adolescent girls, including those with disabilities in Senegal, Togo, and Ivory Coast. So this panel will be in French with translation automatically into English and Spanish. So I will now be speaking French. Bonsoir, Mamoudou. Pourrais-tu nous expliquer comment l'éducation sexuelle complète contribue à améliorer l'accès aux droits et aux services de santé sexuelle et reproductive pour les adolescents, y compris les adolescents et les adolescentes handicapés?
Merci, Anne. Bonsoir à tous. Comme l'a mentionné nos collègues du Soudan, nous sommes aussi confrontés aux mêmes défis en Afrique de l'Ouest. Très souvent, les adolescents ne sont pas conscients de leurs droits sexuels et reproductifs. Et ils ont peu de connaissances sur leur corps, leurs fonctions reproductives, leur sexualité, leur droit à l'autonomie corporelle et à un consentement éclairé lorsqu'ils accèdent aux soins de santé. Il est prouvé que l'accès aux connaissances en matière de santé sexuelle et reproductive dès le jeune âge renforce l'autonomie des adolescents et contribue à favoriser des modes de vie sains. En outre, l'éducation complète à la sexualité contribue à éviter les grossesses non désirées chez les adolescentes, les infections sexuellement transmissibles, y compris le VIH-Sida, et peut permettre aux filles d'aller jusqu'au bout de leur scolarité. Pour les adolescents handicapés, il est encore plus difficile d'accéder à ces informations car elles sont souvent cachées par leur famille ont moins de chances d'accéder à l'école et elles ont plus à risque d'être exposées à la violence basée sur le genre. L'accès aux connaissances en matière de santé sexuelle et reproductive est essentiel pour permettre aux adolescents, handicapés ou non handicapés, de devenir des acteurs de leurs droits sexuels et reproductifs, maîtres de leur santé et de leur bien-être.
Merci, Mamoudou. Est-ce que tu pourrais nous expliquer aussi à travers quelles activités ou comment vous avez réalisé l'éducation sexuelle complète inclusive dans le cadre du projet Ensemble, en donnant des exemples du projet Ensemble?
Merci. Comme l'a dit Anne en introduction, le projet Ensemble est basé dans 3 pays de l'Afrique de l'Ouest, à savoir le Sénégal, le Togo et la Côte d'Ivoire. Nous avons travaillé avec les adolescents handicapés et non handicapés à travers la paire éducation. En effet, nous avons formé 120 pères éducateurs adolescents, soit 50% de filles et 50% de garçons, dont 9 personnes en situation de handicap, pour animer des causeries éducatives interactives avec un kit numérique. 50% de ces pères éducateurs sont du milieu scolaire pour l'animation au niveau des écoles et 50% du milieu extrascolaire pour la sensibilisation en communauté pour les adolescents qui ne sont pas scolarisés, ce qui est très souvent le cas des adolescents handicapés, afin que ces derniers puissent bénéficier de cette éducation et sensibilisation. Le transfert de connaissances d'un adolescent à l'autre est très efficace car ils parlent le même langage. Nous utilisons la communication pour le changement de comportement social et essayons d'utiliser différentes méthodes de communication innovantes. Par exemple, une série télévisée qui a été utilisée, c'est La Vie, sur l'éducation sexuelle sur l'éducation sexuelle, a été adaptée en kit numérique. C'est un outil interactif avec une approche ludique pour atteindre tous les adolescents handicapés ou non handicapés. Ensuite, en collaboration avec les différents ministères, notamment le ministère de la Santé, nous avons également formé 180 prestataires de soins sur la santé sexuelle et reproductive et l'inclusion, afin de rendre les services plus accessibles aux personnes handicapées et plus conviviaux pour les adolescents. Nous avons également formé 120 agents de santé communautaire avec une parité de 50% de femmes, 50% de filles et d'hommes, dont 14 personnes en situation de handicap, ainsi que 114 agents de santé sur l'éducation complète à la sexualité et l'inclusion. Toutes nos activités et formations sont menées avec la participation significative des personnes handicapées et des organisations qui les représentent. Et l'une des recommandations pour nous, c'est le principe « rien sur nous, sans nous ». Et c'est ce que, dans ce projet, nous avons essayé de faire tout au long de la mise en œuvre de ce projet. Et actuellement, même, je suis à Abidjan et sur en fait une activité phare de ce projet ensemble qui est la capitalisation de nos expériences dans les 3 pays. Merci.
Merci beaucoup, Dr. Barro. Et maintenant, je vais repasser à l'anglais. I'm going back to English. So Rosario, I'd like to bring you back and see if we can talk a little bit about how this work requires applying an intersectionality lens to take into account those considerations. And so Mamoudou talked about age and gender and disability, but of course intersectionality lens is even more complex. And that intersectional approach is essential to obtaining informed consent. Rosario.
Yes, thank you so much. Taking an intersectional approach is really important when considering informed consent because it recognizes that individuals' experience and identities are shaped by multiple intersecting social factors such as race, gender, class, sexuality, disability, and more. These intersecting factors can significantly influence how people understand and exercise their autonomy and make decisions about their bodies, healthcare, and participation in research. Here are some key reasons why an intersectional approach is crucial for ensuring informed consent. First, acknowledging power dynamics. Intersectionality recognizes that power dynamics exist within society and can affect individuals differently based on their intersecting identities. These power dynamics can influence the information people have access to, their ability to understand that information, and their capacity to freely make decisions. By considering intersecting factors, an intersectional approach helps identify and address power imbalances that may hinder informed consent. Another issue is recognizing diverse perspectives. Individuals' experience and perspectives are shaped by the intersections of their identities. An intersectional approach ensures that consent processes are inclusive and sensitive to diverse backgrounds, culture, and life experience. It acknowledges that people may face unique challenges or have specific concerns related to their intersecting identities, and it allows for tailored approaches to address these concerns and facilitated meaningful participation. Another issue is challenging stereotypes and biases. Stereotypes and biases can impact how individuals are perceived and treated within healthcare and research contexts. An intersectional approach helps uncover and challenge these biases, promoting fair and unbiased information sharing during the consent process. And by understanding the unique experience and vulnerabilities that can arise from intersecting identities, it becomes possible to counteract discriminatory practices and ensure that consent is truly informed and voluntary. Promoting equitable access to information. An intersectional approach emphasizes the need for accessible and culturally appropriate information. It recognizes that people may have different language preferences, literacy levels, or cultural norms that affect their understanding and decision-making. By taking into account intersecting identities, an intersectional approach promotes the provision of information that is accessible, relevant, and understandable to all individuals, regardless of their social, cultural, or linguistic backgrounds, respecting autonomy and self-determination. Another issue which is important to take an intersectional approach is that informed consent is fundamentally rooted in the principle of autonomy and self-determination. An intersectional approach respects individuals' right to make decisions about their bodies and healthcare based on their unique needs and circumstances. It acknowledges that autonomy is now a universal concept but is shaped by intersecting factors. By recognizing and valuing the diverse identities and experiences, an intersectional approach supports individuals in making informed decisions that align with their values, desires, and self-defined well-being. Overall, an intersectional approach to informed consent is essential for promoting fairness, inclusivity, and respect for individual autonomy. By considering how intersecting social factors shape people's experiences and decision-making processes, healthcare providers, researchers, and policymakers can work towards ensuring that informed consent is truly informed, voluntary, and reflective of individuals' diverse identities and circumstances. Thanks.
Thank you, Rosario. And I agree, there's that thread between autonomy, empowerment. Mamoudou spoke about working with women-led organizations, women with disability-led organizations, and ensuring they're part of designing and identifying priorities. You can see how that thread around decision-making and autonomy makes it to bodily autonomy and informed consent. And so Dr. Gisela Berger, who was unable to be with us today, but who has prepared a short video, will share with her experience working with humanity and inclusion on the Women's Integrated Health Project called WISH2ACTION. And she will share about the management of WISH2ACTION project and how we can make SRHR services more inclusive.
Thank you. To answer the why, I would do it very shortly. It's our national and international obligation, and we never will reach to universal health coverage for all if we don't include everybody, including people with disabilities. The second question is based on our experience from WISH. I would say there are three main aspects we have to consider. The first one is always to work on a multi-level approach. The second one is a close cooperation and partnership with organizations of people with disabilities and other civil society organizations. And the third one is really to support health workers, as well health workers in the field, and to have the health system really to enable and support them to do inclusive, to provide inclusive services. So when it comes to the first level, to say first, to consider we always have to work in three levels, I would think community level, service level, and from the beginning on as well on national level, looking at advocacy. So if we don't work with community, with our clients, people with disabilities and other vulnerable groups to get the services they are entitled to, for example, with SPC and SPCC and so on, it can't work. On service level, to support service providers, to do quality services in regards to inclusion, and to push for advocacy, to make sure policies and systems are prepared really to be enabled to provide such a service. Multi-level. Second, collaboration with OPDs. And here it's as well very much on community level. Our experience was that organizations of people with disabilities really helped and supported us to make sure we reach and the service providers reach the people in the field, but as well to learn from them what needs to be changed. So we had, for example, a wonderful cooperation in Bangladesh where we provided as well services during COVID to people with disabilities in remote area. They got telephone calls from OPD members and community health workers to be informed on COVID and SRHR services during this difficult time. Or we had in South Sudan, in cooperation with OPDs, they could designed with the radio colleagues and the service providers radio talk shows, 340 radio talk shows, broadcasted to people in very remote areas. And so people with disabilities said, first time we were addressed, and we got information. But as well on training level for health workers to include people with disabilities in OPDs, for example, in training, because it's very often they learn from their partner where are the challenges and the barriers. Integration of representatives of organizations of people with disabilities into existing health structures. For example, we did it in some countries where in the community health committees, people with disabilities, OPD representatives were integrated to raise their voice and to help service providers as well to improve the services. And as well, OPD cooperation in regards to monitoring, evaluation, and quality management. Make sure that people with disabilities are integrated in complaint mechanism. And the third part is really to support health workers. We talk about informed consent. It's not so easy when you have to provide service, for example, to a person with intellectual disabilities, and you have 30 people sitting in the waiting room. How do you, are you entitled, do you have the opportunity to take sufficient time to invite the person to come for a second talk and so on? So as well as important to look at committed leadership, to support leadership, to understand the importance of sometimes even structural changes within the organization to enable the implementers to become inclusive, to, for example, as well, to make sure that the national curricula will have aspects of disability inclusion when people are trained, medicals, paramedicals. and perhaps to consider about accredited capacity building programs so that people are interested as well to have this certificate, to know how they can do it, but as well ready to provide structural support to health workers as well from national side to make sure that the people who are working on the field have all the means they need to make it possible to provide services to everybody, including people with very, very diverse disabilities.
Well, thank you to Dr. Gisela Berger for sharing that video with us and the experience of the WISH2ACTION project, which is led by IPPF and is implemented in 11 African and Asian countries, providing really rich knowledge and experience of some of the challenges that are faced as we put this into practice. So moving on to our next and last panelist, last but not least, welcome to Dr. Ingrid van der Heijden. She's also a feminist, a gender and inclusion researcher who developed as a consultant for HI a guidance on disability inclusive consent. And so she will now present the findings of this research and the recommendations for the guidance. So over to you, Ingrid.
Thanks, Anne. Bonsoir, hello. My name is Ingrid. I have brown hair in a ponytail that is slowly going grey. I'm wearing a green blouse, black pants, and I am barefoot. I'm going to talk to you about the practices that we identified among stakeholders in Uganda and Rwanda that may help strengthen informed consent to be more inclusive and rights enhancing. The findings contribute to a guidance document that's produced by Humanity and Inclusion, which I will speak about later. So what do we know so far? In this panel, we've heard about the negative attitudes of health providers, the barriers to information, communication challenges, and the exposure to very harmful and coercive practices within sexual and reproductive health services. We know that a human rights-based approach and a person-centered approach is key to inclusion of all women in sexual and reproductive health care. The voices of clients with disabilities and working with women-led disability organizations and other OPDs are crucial. Intersectionality, as mentioned by Rosario, is also important to recognize, and that clients are not seen as one identity, but many identities with differing vulnerabilities and capabilities that may affect their decisions. So how can healthcare providers strengthen informed consent to make sure it's person-centered and where clients with disabilities can participate equally in the process? Informed consent is a legal requirement and an ethical obligation, and is required to be obtained from the client prior to the start of any examination, treatment, or care. It is actually fundamental to the provision of quality sexual and reproductive health care. Informed consent is a very important communication process. It occurs between the healthcare provider and the client and results in the client giving, withdrawing, or refusing permission for treatment. The provider must present adequate information in a reasonable, accessible manner, in a form and language that's understood by the client, and for the client to communicate their understanding and decision back to the healthcare provider. Now, as we know, this can prove a very difficult and complex exchange. Also within this process, we must determine that the client has capacity to understand the information and options that are presented to them, and that clients' decisions are voluntary and not made under pressure or coerced by other persons. So to provide informed consent, clients have to be legally able to be of age and comprehension level. However, an important barrier is the assumption of the lack of capacity of clients with disabilities. For our research, we have come across that there are many other reasons other than lack of capacity that hinder the decision-making process, such as health literacy, cultural differences, educational levels, and communication issues, including hearing or speech impediment or emotional trauma. We need to remember that clients have diverse needs and come from diverse backgrounds. If comprehension or capacity is ever in doubt, health providers can build on what clients know, be intuitive about the difficulties that they encounter, and try to facilitate inclusion. Capacity and guardianship are very important in the informed consent process. Guardianship is where guardians make decisions on behalf of persons who lack capacity. But guardians by court-appointed authority often don't exist in low-income countries. So this is where the role of informed decision-making supporters become a viable and rights-enhancing option in decision-making. A supported decision-making approach allows a client to make his or own decisions alongside someone trustworthy. It is important for the client to choose who should assist them with their access, communication, or comprehension needs. The supporter has no other influence on the process. The supporter, like a legal guardian, has no authority to decide over termination of parental rights, such as abortion or forced sterilization, and the client makes the final decision. The supporter can be a family member, a friend, or community member. In Uganda and Rwanda, service providers spoke of how family members, through their proximity to clients, may know the client's needs and can play a role in facilitating their access to services and enhancing their rights and protecting them from harm. While it is commonly believed that guardians and caregivers can pressurize or bar access to rights and services, we can view them as potential critical supporters in clients' inclusion in informed consent, especially if a supportive model is carefully monitored by a third party. If all stakeholders partner together and invest time and energy in improving quality and inclusivity of informed consent, there are many benefits. When we empower the client to take an active role in their own health, to select and nominate their own supportive person or tool. It can help strengthen.
Okay, I found this on the web for person. Check it out.
It can help strengthen the client-provider relationship. It's important that family and friends and supporters can be potential partners in promoting client safety. Do no harm is an integral part of informed consent. Quality and informed consent leads to better care, freedom from violence, and better sexual health outcomes. Thank you.
Thank you, Ingrid. What a great way to step into some of the Q&A. So we've had already a great question or comment in the chat from Audrey, who's a pediatric physical therapist, where she highlights the real challenges that healthcare providers face and the importance of investing in continuous professional development. Healthcare workers can enhance their knowledge and skills in working with individuals with intellectual disabilities, for example. And this enables us to, as healthcare workers, to employ person-centered approaches, utilizing accessible communication tools and techniques to promote understanding and empower the girls to make informed decisions about their healthcare. Equally important is empowering the girls themselves through education. By providing them with age-appropriate information and resources, we enable them to better understand their rights, to communicate their preferences, and actively participate in their own care. Audrey writes that she strongly believes that by fostering a collaborative environment and prioritizing knowledge and education, we can overcome the challenges associated with obtaining informed consent for girls with intellectual disabilities, ultimately promoting their rights and well-being. Thank you so much, Audrey. I'm looking to my colleagues here who are helping me with the technical aspects. Let's see. Another question. In order to implement the best practices, and this question will go to Rosario, so get ready, Rosario. And so this question, in order to implement the best practices of the inclusive sexual reproductive health, how do you see the way forward in the public health policies or raising awareness in the communities?
I think both of them. I think it's very important to consider like a twin-track approach. Especially in International Disability Alliance, we are working with twin-track approach. Especially, we need to consider to definitely mainstream disability in all the public policy, but also we need to definitely have services prioritized to different needs, because persons with disabilities have different needs, and also there are underrepresented group of persons with disabilities. That's why I think that a great combination of both, like having like inclusive policies, public policies, and also services in the communities really help support to have this progress in the sexual reproductive health rights.
Thank you, Rosario. I think we are coming to our closing remarks, which works out. We would love to continue to receive your questions, and I'm sure we can share them with our panelists and answer them perhaps via email after the panel. But I will pass it over to Rosario for a call to action to governments, to health and sexual reproductive health and rights service providers, to OPDs on the way forward. Please, Rosario.
Thank you so much for inviting me to do the closing remarks. I think in today's panels, speakers have highlighted the often silent challenges that women and girls with disabilities face in their daily lives due to the lack of enabled environments for inclusive sexual and reproductive health and rights, as well as lack of accessibility of most healthcare services. We have heard that barriers to healthcare and SRHR for women and girls with disabilities can include physical inaccessibility of healthcare facilities, lack of trained healthcare providers who understand their specific needs also can include negative attitudes and stereotypes about their sexuality and limited access to information and education about SRHR and lack of decision-making autonomy. These barriers can also intersect with other forms of discrimination, such as gender-based violence and discrimination based on disability. Despite the CRPD upholding the rights to health in Article 25, or the right to form a family, Article 23, or equality recognition before the law in Article 12 and others, the women and girls with disability keep facing nowadays different violence and discrimination in sexual and reproductive healthcare settings. As we have heard from today's panel, realizing that sexual and reproductive will require concerted interventions and collective efforts at multiple levels. That's why we need to do like a call to action, especially for governments. In case of the governments, fairly needs to create a clear and enabling policy and legislative environment to uphold persons with disabilities capacity to concept inclusive, accessible, person-centered approaches to the provision of SRHR. Then the governments also need to ensure the participation of women and girls with disabilities in the consultations and also in the formulation, execution, and monitoring of sexual and reproductive health policies and programs. For health service providers also, we need a call to action for them to create an enabling environment working to address attitudinal, communication, environmental, institutional, and policy barriers that all patients, especially women with disabilities, face in the healthcare services. To ensure feedback and compliance mechanisms can be accessible for all persons with disabilities, for women and girls with disabilities, and including plain language, easy to read, and other formats. And also for civil society, it's necessary to empower rights holders to know their rights and support them to self-advocate in healthcare settings, to strengthen the capacities of organization of persons with disabilities, to keep track on the advance of the sexual and reproductive health rights, to support the creation of enabled environments, and to keep monitoring the implementation of the Target 7 of the SDG 3. In this regard, I would like to emphasize that International Disability Alliance is encouraging OPDs to monitor the implementation of the 2030 agenda to include persons with disabilities, in order that persons with disabilities can know if the governments are including them in monitoring the 2030 agenda, especially SDG 5 regarding gender equality, and SDG 3, especially the Target 7 regarding reproductive health. And finally, I would like to make an invitation to governments, international NGOs, OPDs, and all stakeholders to work together to create safe, inclusive space for women and girls with disabilities, to ensure that they receive the highest attainable standard of healthcare, and also to invite that in the negotiations post 2030 agenda, which will be starting on 2025, we need to find a space. We need to continue do all the efforts to include sexual health and reproductive rights. Thank you so much.
Thank you, Rosario. 2:31 on the nose. That was amazing. The timekeeping as well. And I'm quite impressed that we managed to stay on time given the large number of speakers. But I want to thank all of you for participating today. And really, you know, it's such diverse perspectives from various parts of the world. And nonetheless, the messages resonate over and over about the importance of including women and girls with disabilities in sexual reproductive health and rights services to advance their rights and ensuring informed consent. So thank you so much, everyone, for joining us today. And thank you also to our team of interpreters who have been doing an incredible job and without whom this would not have been possible. Thank you and goodbye.